I'd like to start off just by echoing Darcy's comments to thank the organising committee for this opportunity to speak with you today, and also just to let you know that in the few days I've spent here in Israel, I've fallen in love with your country. You're truly very blessed to live here. It's a beautiful country. So thanks again for the invite. My task today is to speak to you about skeletal muscle dysfunction in patients with chronic obstructive pulmonary disease. So the overview of this presentation is I'm going to start off with a few slides to try and convince you that COPD should no longer be seen as a disease just of the lungs, and it's in fact a systemic disease. And of those systemic manifestations, I'm going to focus predominantly on skeletal muscle dysfunction. I'm then going to talk you through the nature of that skeletal muscle dysfunction, so with an overview about the problems with the quantity of muscle, then the quality of the muscle that remains, and then the implications of this skeletal muscle dysfunction, both in terms of the patient's capacity to move around, so exercise capacity, and also in terms of survival. And I'm going to focus for the last maybe 10 or 12 slides on how we can treat that skeletal muscle dysfunction, which, as you've already heard from Darcy, is predominantly with exercise training. So we all know that COPD is a disease that's characterised by airway inflammation, and that's a process that's set off in response to the inhalation of noxious particles or gases such as those found in cigarette smoke, and that results in damage within the lungs and the airways. And this damage culminates in a process of fixed airflow obstruction and pulmonary hyperinflation. And those of us that have treated patients with COPD are probably all pretty familiar with an X-ray like this, which shows large distended radiolucent lungs, and also this characteristic flat shape, horizontal and inefficient shaped diaphragm. But in addition to these primary pulmonary manifestations, there's now recognition that the systemic manifestations of COPD are equally important. And amongst these, the systemic manifestations include cardiovascular disease. In fact, patients with mild to moderate disease, their leading cause of death is one of cardiovascular disease. And it may also be of interest that patients with COPD are 2 to 3 times more likely to be hospitalised with a cardiovascular disease or a cardiovascular event than their non-COPD counterparts. We also know that with regards to systemic manifestations, there's changes in body composition, and this is predominantly a loss or preferential loss of fat-free mass or muscle mass. We also know that patients with COPD are at increased risk of osteoporosis, and the clinical implications of this are increasing as we now recognise that patients with COPD have important impairments in balance, and they report a high incidence of falls. And coupled with osteoporosis, that places them at increased risk of fall-related fractures, which, as we know, in the elderly population can be catastrophic. Patients with COPD also have a high prevalence of psychological consequences. In fact, between 30 to 40% of COPD patients have clinically diagnosed general anxiety disorder or clinically important depression, and this can impact on their ability to participate in a pulmonary rehabilitation program and also their healthcare utilisation. But in addition to these systemic manifestations, the one I'm going to focus on today is one of skeletal muscle dysfunction. So what are the causes of skeletal muscle dysfunction? And in fact, many of these causes relate to the other systemic manifestations. They include systemic inflammation, malnutrition, and these are particularly important in late stages of the diseases where patients are so acutely dyspneic they have difficulty eating. Corticosteroid use, and in fact, corticosteroid use, Mark de Kramer's labs demonstrated that the average daily dose of corticosteroid use over a 6-month period only needs to be as low as less than 5 milligrams a day in order to be strongly related with quadriceps force. So quite trivial amounts of corticosteroids can lead to clinically important myopathies. Hormone disturbances such as a reduction in growth factors and in testosterone, and gas exchange abnormalities, which we've touched on a little today, but probably the most important of which is hypercapnia, which has been demonstrated to impair muscle contractility, increase fatigue and reduce endurance. But in addition to all of these causes, there's one that really eclipses the primary cause of skeletal muscle dysfunction, which Darcy's spoken about, which is a sedentary lifestyle. And we all have no doubt seen the Disney Inactivity cycle when we're at med school or physio school. And the theory goes that patients with COPD experience an impairment in lung function. And this impairment in lung function needs to be quite dramatic before patients notice dyspnea during day-to-day life, given that our lungs are really overbuilt for activities of daily living. So it's really when patients experience a decrement down to around about 50 or 60% predicted that they'll start to notice dyspnea with strenuous activity. And this will be dyspnea with activities such as walking up hills or walking upstairs. And dyspnea by our cortex is perceived in a very similar way as pain. It lights up the limbic system in the same way, and it's perceived as an incredibly noxious sensation. So it's just human behaviour to do everything in your life to avoid it. And as a result, patients avoid doing this strenuous activity. As their lung function deteriorates, the cycle continues such that they now experience dyspnea with moderate activity. Before long, they're avoiding anything to do with moderate activity, which would be going for a walk with a spouse, walking the dog, anything along those lines. Before long, they're experiencing dyspnea with mild activity. And it's really at this point they're in crisis. These patients have difficulty showering, dressing, grooming, just getting through day-to-day life. And before long, they're avoiding all activity. And in fact, the most dramatic patients that I've ever treated in pulmonary rehabilitation have been the ones that have been wheeled in by a loving next of kin, normally a daughter or a spouse, in a wheelchair, and have been told that, mum has lung disease, and she's been told to take it easy. And she's taking it easy to that point that she's spending her life in a wheelchair. And when I go through questionnaires and trying to understand how dyspneic she is during day-to-day life, I can't get a read on her because she's doing nothing. So I literally can't find out how dyspneic is. She's avoiding it that much. And we've long believed that patients with COPD are inactive, but we now have robust data to demonstrate that. And this is data that Fabio Pitta, who's a physiotherapist, collected as part of his PhD with Rick Gosling's group in Leuven in Belgium. And he asked patients with moderate disease to wear an accelerometer, which was a state-of-the-art physical activity monitor at the time, for 2 consecutive days over a 12-hour period. And he basically watched what they did over that period of time. And he compared that with healthy elderly individuals who are of the same gender and the same age. So over a standard 12-hour period, so during daylight hours, these patients with COPD, you can see, spent significantly greater time sitting compared with the healthy elderly, and more time lying. And they did this at the expense of weight-bearing exercise. They did this at the expense of standing and walking. These patients are spending maybe 30% of their day upright. The rest of their day, and this isn't nighttime, this is daytime, the rest of their time they're spending sitting or laying down. And this data has been replicated by several labs, including Roger Goldstein's, demonstrating that these patients are profoundly inactive. And these are patients with moderate disease. So you can only imagine what happens when they get more severe. So we now understand that although dyspnea leads to inactivity, this is a two-way street. And in fact, inactivity leads to dyspnea. So we know they have reduced activity, and this reduced activity gives rise to profound peripheral muscle deconditioning. The muscles are terribly atrophied, and we'll talk about that later on. The consequence of this is that they have reductions in aerobic capacity, and I'm going to speak to you about the specific manifestations that lead to that reduction in aerobic capacity. But the reduction in aerobic capacity means they have greater reliance on their anaerobic energy systems early in exercise, which means they produce lactic acid unusually early and an unusually large amount of it. And this is true at any given exercise intensity with these patients. And as we know, lactic acid is a potent ventilatory stimulant. It increases CO2 production, and the hydrogen ions drive your chemoreceptors crazy, basically. And these patients have, therefore, a lot of ventilation and no capacity to deal with it. And they perceive that as dyspnea. That's one of the reasons these patients are so dyspneic, and how peripheral muscle dysfunction contributes to that sensation. So I'm going to talk now about the nature of this dysfunction, and for the majority of the talk I'm going to focus on the muscles of locomotion, and in particular the quadriceps muscles, because this is where the majority of the research is. So let's just talk about it from a macroscopic perspective. So if you look at a patient with COPD's legs, basically, they have less muscle. And this is an elegant study that's quite old now, that was done by Francois Maltese group in Quebec, Canada, where he took patients with moderate to severe COPD and he put them all through a CT scanner and looked at the cross-sectional area of the thigh. And you can see here, this is a healthy individual who has a cross-sectional area of about 120 centimetres squared, and this is a COPD, which is about 80 centimetres squared, or square centimetres. So it's a reduction of between 30 and 40% just in the amount of muscle they've got. These are patients with quite moderate disease. There's just less muscle. Of course, now we probably see more adipose tissue on the outside here, but still, underneath the adipose tissue, there's less muscle. And what are the functional consequences of this? Well, the consequences is that they're weak. The single greatest contributor to force generating capacity or strength is the amount of muscle you've got. So if you've got less muscle, you've got less force. And this again is work out of Rick Gosling's lab, who's one of the leaders in this area, who's looked at knee extension force. I'm just going to get you to focus on the red bar for now. These are healthy controls, COPDs, knee extension force. So he's put them up in a hydraulic dynamometer and he's asked them to extend their knee forcibly, as strongly as they can, and got a read on their force. And you can see here in healthy controls it's around about 360, in COPD it's about 260, and this number expressed as a percentage of this number is 76%. So a reduction of around about 25%, which is pretty similar to what we saw in terms of the depletion of muscle mass. Everything's gone down by about 20 to 30%. The consequences of this are that these patients will struggle to rise from a low-level chair without pushing up with their arms. They're weak. So let's move away now from the amount of muscle they've got and think about what the quality is of the remaining muscle. And unfortunately, it's a double-edged sword because the quality of the remaining muscle is poor. This again is work from Francois Maltais' lab, who's specialised in this area really. And he took a biopsy of vastus lateralis, so the most lateral muscle of the quadriceps complex. And he did some fibre typing. He's got this here in healthy controls in this kind of silver or grey bar, and COPD in the blue. The first thing you can notice here, if you look at the proportion of different fibre types here, there's a dramatic reduction in the type 1 fibres, the proportion of type 1 fibres in the muscles. So for those of you who can't quite remember, Anatomy and Physiology 101 from med school, type 1 fibres are the oxidative muscle fibres. They're fatigue resistant. They're the ones that rely on oxygen to produce energy. They're the ones that would look more red on staining. And you can see here, in addition to this reduction in type 1 muscle fibres, we see a corresponding increase in the proportion of type 2B fibres. So type 2B fibres are your fast twitch muscle fibres. They become fatigued very easily. So you can see here there's this shift away from the muscle fibres that are efficient and use oxygen towards the muscle fibres that rely on anaerobic metabolism very early. But the story gets worse. If we stop looking just at the fibre types and look at the fibres themselves, the blood supply, or the capillarity to those muscles, is reduced as well. So you can see here in terms of the number of capillaries that are touching each of those muscle fibres, in COPD there's significantly less than normals. So in other words, not only is there less muscle, the muscles have shifted now so that you've got less oxidative fibres. Those oxidative fibres have less blood supply. And ultimately, if we go even one step further and actually now look inside the mitochondria, they've got less enzymes with which to utilise oxygen. So this is from the same group, the same muscle. This is the concentration here, or aerobic enzyme activity of citrate synthase, and this is 3-hydroxyl-CoA dehydrogenase, or HADH. These are two enzymes that exist within the Krebs cycle and allow you to use oxygen to produce ATP. And if you have a look here, this is the normals, and this is the COPDs. Significantly reduced. So to summarise, they've got less muscle. The muscle they have is myopathic. There's a shift away from type 1 fibres to type 2 fibres. Those type 1 fibres have less blood supply, and if you go inside the cells themselves, they have less oxidative enzymes to be able to utilise oxygen. So what does all this mean? And what this means is they favour anaerobic metabolism. So if you have a look here, this is oxygen uptake on the x-axis and lactate here on the y-axis. This is a representative healthy individual, and you can see they can actually get quite far into exercise before you see this point of inflection and they start producing more lactic acid. So you're producing lactic acid all the time while you're exercising, but at some point you start producing more than you can utilise. So you start accumulating it. And at this point here, they'll perceive dyspnea. We all perceive breathlessness as well if we get to this point. But if you have a look at COPD, they're producing it very, very early in exercise. It's unusually steep. So even during these activities of daily living, these patients are producing huge amounts of lactic acid, which is what drives their ventilation crazy and makes them very breathless. So that's some of the functional consequences. But let's now think about the impacts on survival. And we're now increasingly realising that some of these systemic manifestations, in fact, may impact on survival independently of lung function. Again, this is from the same group, Francois Maltais' group, and this was a really interesting study. He took a large number of patients with COPD, and in the first instance he grouped them according to whether they had an FEV1 of above 50% predicted or an FEV1 of below 50% predicted. So they had some preservation in lung function, they had pretty poor lung function. And then he redivided that group according to whether or not they had preservation of muscle mass or depletion of muscle mass. And he followed them up over a period of time and looked at the proportion who survived this follow-up period. This top line here is people that have preserved muscle mass and preserved lung function, and you can see they do pretty well. This next line down here are people that have the same lung function as this group, but have small muscles. And you can see already there's a signal. You can see already their survival's compromised. But look at this. These are people who have an FEV1 of less than 50% predicted, but some preservation of muscle mass. Not too bad. And look at this is the comparator group. So less than 50% predicted and small muscles. And they're on a very slippery slope here towards not surviving the follow-up period. This is not cause and effect data. So this does not tell us that if we increase muscle mass, that will confer a survival benefit. That's not what this is telling us. But when I see a patient in front of me who's got poor lung function and skinny legs, I think, how can I get you off this and onto this trajectory? Because that's got to be a better trajectory for you. So how can I increase your muscle mass? So let's talk about how we treat the muscles. And the answer is high intensity exercise training. And as Darcy's already said, it's really with regards to cycling and walking based exercise training, and this without any doubt should be the backbone of any exercise training program that you offer a patient with COPD. Anything else is additional and nice, but this has got to be the backbone. This is where the money is. How does it work? And again, this is from the same group. You've seen a slide like this similarly. So this is about oxidative enzymes. This is prior to training. Again, they've gone in and biopsied the vastus lateralis, looked inside the mitochondria of these muscles. This is before, and this is after. So a significant increase in the capacity of the muscles to utilize oxygen to make energy. And so what's the upshot of this? Oh, by the way, there's also an improvement in capillarity, and there's also an improvement in muscle fibre size. So what does this mean for the patients? And this is probably one of the most famous studies in pulmonary rehab literature, I think, and probably one of the most famous figures. This is oxygen uptake here on the x-axis and lactate here on the y-axis. This is prior to training. So prior to training, these patients get to this level of exercise intensity before they exhaust their aerobic systems, and they now need to start relying on their anaerobic systems, and they start producing or accumulating lactate faster than they can utilise it. So in this period here, they'll be acutely dyspneic. They won't be enjoying exercise at all. And let's have a look at post-training. You can see post-training, they now get out to this point, before this point kicks off again and they start producing lactic acid. So that means that between here, this level of exercise intensity here, out to this level of exercise intensity here, these patients are not feeling much dyspnea. Between here and there is the difference between being able to play with your grandchildren and not. The difference between here and there is the difference between able to walk down to the back of your block or back of your yard and do woodwork for 2 hours. The difference between here and there is the difference between able to shower without needing to rest or not. No wonder these patients have a huge improvement in their quality of life. So the upshot is less dyspnea and increased exercise capacity. All of the training studies to date that have really looked at the mechanisms have focused on cycle-based training. And that makes sense because you're going to get more bang for your buck with cycle-based training because you have more load on your quadriceps. But in all the time I've done pulmonary rehabilitation, I've never had a patient come in and say to me, you know, Kylie, the thing that bothers me is I just can't cycle. I just can't cycle around the house, or I can't cycle to my friend's house. Patients don't cycle during day-to-day life, they walk. That's the thing that bothers them. So I think walking-based training is an integral component of any pulmonary rehabilitation program. It has much greater functional relevance. Patients walk during day-to-day life, they don't cycle. It's much easier to replicate in day-to-day life, and this builds into Darcy's comment about it being a lifelong process. If they only have access to a cycloergometer when they're with you, they can't replicate that at home. So they have to do walking when they're with you because it's the only form of aerobic exercise training these guys can probably do at home. And you can also manage it with minimal cost and minimal equipment. In fact, we've done a study just recently to show that walking-based training alone, as the only form of modality, confers huge clinical benefits in terms of exercise capacity, quality of life and symptoms. This is a study that came out of a group in Sydney, a group of physios again, and they randomised patients to either walking-based training, high-intensity walking-based training, or high-intensity cycle-based training. So they've put two very, very effective training modalities up head-to-head. It's a pretty risky study, really. And they've done here endurance. This is the outcome measure here is the endurance shuttle walk test. So this is the ability to walk at a sub-maximal intensity for as long as you can, about 85% of your maximum for as long as you can, and it's measured in time, so until the symptoms basically overwhelm you. And with walking-based training, they saw an improvement of around about 440 seconds. In cycle-based training, still statistically significant, up to 160 seconds, but look at this, the difference between the groups was statistically significant. So if you want your patients to walk further, they need to walk. I'm not suggesting cycle-based training isn't useful, it is, but they have to walk. Walking is very important. The reality is we don't quite know what the mechanisms are. It amazes me that no one's gone in and done a biopsy study before and after walking-based training, but we're gearing up to do that in Perth. So let's summarise what are the effects of exercise training, and there's now been 31 randomised controlled trials to demonstrate this in stable patients and 9 randomised controlled trials following an exacerbation. So the data, the evidence is level 1A, it's as strong as it gets. It increases exercise capacity. This is aerobic exercise training. It reduces symptoms of dyspnea and fatigue. It improves health-related quality of life, and it reduces healthcare utilisation. It's one of the only therapies you can offer your patients where it will cost you less than you will save. It will cost you less to implement this. You will save more money by implementing it. And this evidence is very robust in both stable disease and those immediately following an exacerbation. So what do the current position statements say with regards to what is the minimum that we should be offering these patients? So this is the minimum, not the maximum. As a minimum, we should be offering an 8 to 12 week program. They should be training a minimum of twice a week, and this twice weekly supervision should be twice weekly exercise should be supervised, and this should be in addition to a home program. I think one of the problems with the maintenance studies to date is that we don't actually encourage the home program early enough. The patients become very reliant on us, and they come to the physiotherapists for supervised exercise training, but they need to know how to do this on their own. So they need to be encouraged to do a home exercise program from the beginning. So in our program, we do twice weekly supervised, and we encourage them to do a home exercise program on 3 other days. And they have a logbook, and they're accountable when they come in. Each of these sessions comprises a minimum of 30 minutes of lower limb endurance training. Everything else is additional. They have to walk, they have to cycle, and then we put some weights in. The modality, as I've said, is usually walking or cycling. And with regards to high intensity, as Darcy said, the jury's not quite out on this. I think high intensity exercise is the one that will confer physiological benefit. So when I'm showing you those changes in lactate, that's all about high intensity training. If your patients can't tolerate high intensity training, low intensity training has strong evidence for conferring clinical benefits. So 6-minute walk distance, quality of life, dyspnea, fatigue, but you won't see those changes in lactate, and we don't know that it has the same capacity to condition the peripheral muscles. So I'm just going to spend a few slides talking about how we actually prescribe it. You know, I think as physiotherapists or exercise physiologists or physicians that are prescribing exercise training, we can do no greater injustice to our patients than to say, just go for a walk or just go for a bike ride. We should be prescribing exercise training with the same level of rigour as we prescribe medications, with the same level of precision. So I think it needs to have a scientific approach. And you can do that. It's very, very possible within the realms of clinical practice. I'm going to talk about, first of all, how you would use a 6-minute walk distance to prescribe a walking-based training program. And this is because every program can do a 6-minute walk test. You may not have the capacity to send the patients off to a laboratory to be tested on a treadmill or tested on a bike, but everyone can do a 6-minute walk test. So in our program, we prescribe a walking-based training program at an intensity that's a percentage of the average walking speed they achieve during the 6-minute walk test. I'm going to talk you through an example in the next slide. I guess the question is, what percentage? We know that patients with COPD can tolerate quite a high percentage of their walking-based, quite a high percentage of their average speed that they achieve during the 6-minute walk test. In fact, they can tolerate relatively higher training with walking than they can with cycling, and we can talk about that later if you're interested. So the question is, what percentage? And the reality is that 80% has been demonstrated to be feasible and effective, and there's published literature around this, more studies in this now. So let's go through an example. In our program, we start off with a 20-minute corridor walk. We do 20 minutes of corridor walking and then 10 to 15 minutes of cycling. We bias the walking-based training. As I spoke to you before, it has much greater functional relevance, and these patients can do it at home independently. So let's go through an example. Let's say someone's 6-minute walk distance is 450 metres. Their average, if they can walk 450 metres in 6 minutes, they can walk 4.5 kilometres in an hour. So that's their average walking speed. We've said the suggested training intensity is about 80% of that. So 4.5 multiplied by 0.8 brings it down to 3.6 kilometres an hour. That's the speed we're after. If they can do this in an hour, just divide this through by 3, and their target for their 20-metre corridor walk would be 1.2 kilometres an hour. So in our clinical setting, we're lucky enough to have a 50-metre corridor. So they would walk 50 metres down, 50 metres back. That's 100 metres. This patient would get a target to do 12 laps. We would tell them at the beginning we want them to do 12 laps, and we would watch them closely and we would give them feedback about whether they need to speed up to get that goal. And patients get this pretty quick. Let's talk now if you want to do cycle-based training, which I think you should be doing. The position statements recommend that we should be going for 60% of the maximum work rate achieved during an incremental cycloergometry test. So if you're one of the centres that's lucky enough to have routine access to an incremental cycloergometry test, then it's just maths. So the maximum work rate's 50, multiply that by 0.6 comes down to about 30 watts. Because these guys have already done, my guys have already done a 20-minute corridor walk, and exactly for the reasons Darcy was saying, I don't want them to be complaining of delayed onset muscle soreness the next day. I want them to enjoy their first few sessions at least. I would start off with quite a short duration on the bike. So around about 4 minutes, and gradually increase it. The goal is to get it up to at least 10 or 15 minutes, so you're doing a minimum of 30 minutes of aerobic training. So start off with a 20-minute corridor walk, come back and do 4 or 5 minutes on the bike, and then build the bike up quite quickly, allowing for delayed, so that they don't have delayed onset muscle soreness. But the reality is the majority of programs, I think, don't have access, routine access, we certainly don't, and I know West Park doesn't, to incremental cycloergometry test or a lab-based test of exercise capacity before these patients come through. They're resource intensive, they're expensive to do, and not all centres have them. And certainly centres outside metropolitan regions are even less likely to have them. So the reality is you're probably going to have to base cycle-based training using the results of a 6-minute walk test. Well, the good news is that the 6-minute walk test and maximum work rate on the bike are measuring the same construct. They're measuring exercise capacity. And as a result, they're quite strongly related. So you can use the 6-minute walk distance to estimate maximum work rate. And there are a couple of different published equations, but this is one that I particularly like. So all you need here is a 6-minute walk distance and the patient's height. You put this into the equation and do the maths, and it will estimate maximum work rate for you. Just a word of caution. If you have a look here for someone's maximum work rate that's around, I'll say 6-minute walk distance is around about 500 metres, you can see there's quite a bit of scatter. So someone might be getting as high as 90 watts, someone might be getting as low as 30 watts. And the way this regression equation works is just to collapse all that variability down to a single point. So for some patients, this just gets you in the ballpark. You'll need to up titrate or down titrate according to symptoms on the first day. So you need to watch the patients closely. So let's do an example. If someone's 6-minute walk distance is 400 metres and their height's 1.76, you just put these numbers into the equation, do the maths, and it will estimate maximum work rate for you. In this example, it's about 60 watts. Work out what 60% of that is, 36 watts. So I would base this person's initial training on the bike as close as I could to 36 watts. And I would up titrate or down titrate according to symptoms. Okay. In addition to not setting the initial targets scientifically, I think the other great injustice in pulmonary rehabilitation is not to progress them adequately. They need to be progressed. And these patients can progress quite rapidly over the first 4 to 5 weeks as they start to build confidence in both you as a trainer and also in their body to know what they can do. So for walking-based training, you've got the options of increasing time, increasing speed, or for those who are quite high-level patients, we'll actually put them on the treadmill with an incline. For cycle-based training, as I said, I usually increase the time, get them out to about 10 or 15 minutes, and then start increasing the work rate. The current position statements make this statement: we should be aiming for symptom scores on the Borg category ratio scale to be between 4 and 6. I have a bit of a problem with this, because for those of you who know the Borg scale, 4 is anchored with somewhat severe, 5 is anchored with severe, so 6 implies that we're asking these patients to exercise with more than severe symptoms, which when I'm watching a patient in front, they're probably quite happy to exercise to the point they feel very, very uncomfortable, but when they go home, that's not going to happen. So in our clinical program, we aim for Borg scores of 4 because I think that they're feasible, they're safe, they're effective, they're well tolerated, and the patients are much more likely to continue with that when they get home. This here is also building on some of the concepts that Darcy spoke about. So pulmonary rehabilitation has achieved level 1A evidence for improving exercise capacity. It's not open for debate, but those randomised controlled trials talk about groups of patients. And within those groups, there are individuals that don't respond tremendously well. In fact, up to 20% of patients will be so-called non-responders, where you won't get a huge improvement in exercise capacity. And there's some literature around why that might be, and one of the biggest predictors that these patients are characterised by profound ventilatory limitation. These are the people that would get up over their MVV during exercise, so their maximum ventilation expressed as a proportion of their MVV is over 100%. They have profound ventilatory limitation, and as a result their lungs just simply limit them from getting enough of a training intensity that you can actually get enough stimulus on the peripheral muscles to train the peripheral muscles. So I think now in pulmonary rehabilitation we've seen a real shift away from studies that have tried to demonstrate effectiveness, because we know that. And now we've seen a change in the data or studies, the emphasis of studies, to try and change these so-called non-responders into responders. So adjuncts, what else can we add in to try and change this load-capacity relationship such that we can actually give more load to the peripheral muscles in light of this very limited lung capacity? And there's a few things you can do in clinical practice that are pretty easy, and there's a few things you can do in clinical practice that are not so easy. The easy things, I think Roger's going to speak about this a little bit later on, but one's a rollator. So actually giving those patients who are very, very breathless a four-wheeled walking frame to walk with, the ones with the four wheels, has been demonstrated to reduce dyspnea on exertion and increase 6-minute walk distance. And that's about mechanics, and again I'm happy to take questions about that if you're interested. So if your patient needs to stop and rest during a 6-minute walk test, or they need to haul oxygen with them, they should be given a rollator. It'll make a huge difference to them. Interval-based training, so this is just simply interspersing work periods with regular rest periods, and the rest allows for relief of this intolerable dyspnea and usually leg fatigue on the bike, and you can optimise the work rate they can manage during the work periods. Partitioning, which is what Darcy spoke about, with instead of cycling with 2 legs, cycling with 1 leg. Supplemental oxygen, not difficult to do, a bit controversial about how much it works. It's also a bit controversial if you can actually only offer supplemental oxygen at the hospital where they come in to do their exercise. What happens when they go home? Inspiratory muscle training, also quite simple to do, but the evidence isn't particularly strong. These are not so easy to do. Electrical stimulation, helium hyperoxia is expensive, non-invasive ventilation is difficult. There's only one study on this, and testosterone and creatinine supplements, the data's not as strong, and there are issues about systemic side effects of giving people testosterone. So I think watch this space. This is where the data's coming in pulmonary rehab. I do want to touch on resistance exercise because I do think it's an important component of pulmonary rehabilitation, and the reason is this, is if you have a look here, this is at the completion, this is a percentage change after training, this is thigh muscle cross-sectional area and muscle force across a bunch of different other muscles. This is in a program here that just did aerobic training, so cycling and walking. And you can see here at the completion of just aerobic training, you actually get pretty minimal change in thigh muscle cross-sectional area and also pretty modest changes in force generating capacity. And that's not surprising. We haven't actually tried to improve the strength of the muscles, we've tried to improve their oxidative capacity. But if you have a look here at the addition of adding in strength, you can see there's much bigger bang for your buck. So if you actually want to change thigh muscle cross-sectional area, if you want to change strength, you need to do resistance exercise. So there's now level 1A evidence that exercise training, when you add strength to aerobic training, you will confer greater gains in muscle mass, which is important because we know that's a predictor of survival. It'll improve muscle strength, which we know is important because these patients are weak and they have difficulty getting up out the chair. But in terms of other functional outcomes, dyspnea, quality of life, exercise capacity, symptoms, you've already got it. You won't get more by adding in strength because you've already got it with aerobic. So I think when you add strength-based training in, you need to be aware of why you're doing it. You're not doing it to get exercise capacity, symptoms, quality of life. You've got all that with aerobic. The reason you're doing it is to add in muscle mass, muscle strength, and functions such as sit to stand from a chair. So the current recommendations, these will be the current recommendations in about 6 months. For lower limb resistance training is that we should start off with 1 to 3 sets of 8 to 12 reps, starting at very low loads. Starting at reasonable loads, between 60 to 70% of 1 RM. So that 1 RM is the maximum load that you can lift safely through full range once, but you couldn't lift it a second time. So 60 to 70% of the maximum force generating capacity. And again, to try and minimise delayed onset muscle soreness so the patients aren't sore, you might start off a little bit lower for the first few training sessions and try to build up. This is what the position statement will say. Now, call me old-fashioned, but I'm a little bit anxious about taking a patient with myopathic muscles and testing them by asking them to heave as much weight as they can once through full range. I don't think that's best practice. So in our clinical program, we actually don't encourage patients with myopathic muscles to do 1 RMs. We actually get them to train at the 8 to 12 repetition maximum. So this is the maximum load that they can lift safely through full range between 8 and 12 times, but they couldn't lift it a 13th. So you've got fatigue after 8 to 12. That's how we do it. We also combine these combine our strength with our endurance by making the tasks functional. A lot of the studies that have looked at strength-based training have used multi-gyms, which is great, but patients don't have multi-gyms at home. So no wonder that you can see a bit of a drop-off once they leave the pulmonary rehab program because they don't have access to that equipment. So we make these lower limb strength-based training functional, and we get them to do things like half squats, sit-to-stand, step-ups, which they can replicate in the home environment. And if they're doing that in conjunction with a home program, hopefully you'll see some maintenance of benefit. I just want to touch briefly on the upper limb, because we've spoken quite extensively about the lower limb, particularly the quadriceps, but I do want to spend a bit of time talking about the upper limb, because overhead upper limb activities is something that patients almost consistently will report as something that very much troubles them with acute dyspnea during day-to-day life. They all complain of difficulty with, putting groceries away or hanging, washing out, or grooming, so showering. And the muscles in the upper limb are not that dissimilar to the lower limb in that they're also weak. So if you have a look here, you've already seen this table because we looked at this line here before. But if we have a look at muscle force, shoulder abduction force, so the ability to lift your arms up out to the side, is around about 70% of normal. And the decrement is much more modest with elbow flexion and hand grip force. And this makes sense to me because it's the overhead activity that makes them breathless, so that's what they're avoiding. Lifting groceries, turning taps on and off, things that naturally condition your biceps and condition your finger flexors, don't make them particularly breathless. They don't particularly avoid doing those things, they avoid overhead activity, and that's the reason this decrement is so dramatic. So just some evidence that there is in fact a reduction. This again is oxygen uptake here. This is with leg exercise, supported arm exercise, unsupported arm exercise, and COPD and healthy. So you can see here, compared with the healthies, the COPD have a dramatic reduction in oxygen uptake during lower limb exercise. We know that. We know they have difficulty with laboratory-based tests such as treadmill walking or with biking. But you can also see there's a significant reduction in supported arm exercise, so this is arm cycling on those arm ergometers, versus unsupported arm exercise, which isn't like an overhead shelving task where we just get them to lift their arms up and down repetitively. So we know there are reductions. The reality is there are far fewer studies that have gone in and biopsied a muscle in the upper limb in patients with COPD. Tons in the quads, not as many in the upper limb. And those that have gone in have biopsied middle deltoids or biopsied latissimus dorsi, and the data is inconsistent. There's not that shift that we see in the lower limb muscles to favour that anaerobic metabolism. The muscles look odd, they're angulated, the muscle fibres, and they don't look healthy and normal, but there's not that shift. We don't see the change in fibre type proportion, we don't see the change in capillarity, and we don't see the change in oxidative enzymes. So the question is, why all the difficulty? If the muscles aren't that myopathic, why are they struggling so much with lifting their arms up? And the reason relates to an impairment in pulmonary mechanics. So if you or I lift our arms right up above our head, we will increase our end expiratory lung volume by around about 170 mils. It's just physiology, and it happens in COPD as well. The problem is that patients with COPD are already horribly hyperinflated. So when you add an extra 170 mils to the end expiratory lung volume, it becomes catastrophic for them. They become very, very breathless. So you see a further flattening of the diaphragm, shortening of the diaphragm, inefficiency of the diaphragm. And on top of that, the situation gets worse because with the COPD patients, they'll spend most of their life splinting, so they can use their accessory muscles to take the load off their diaphragm. And now we've said you can't do that. Take your arms up above your head. So now this flattened, shortened, inefficient diaphragm is the only muscle of respiration. This worsens the load-capacity relationship, and they perceive that as intolerable dyspnea. So there is most definitely a role for upper limb exercise training in patients with COPD. And there's now been a couple of randomised controlled trials and a couple of meta-analyses that have been published just over the last few years. So there's quite strong evidence now that arm exercise training will improve arm exercise capacity in these patients, and it will improve their ease to undertake activities of daily living. And it does that largely through desensitisation to this experience of dyspnea, and there is some change in ventilation at a given work rate, but it's largely about desensitisation. So in our program, we do overhead arm activities with weights because we know that it's the peripheral muscles here that are weak, not the biceps, not grip, so we don't really do much with biceps. It's all overhead activity with the weights because we know this is where the weakness is. We also do unsupported arm exercise, so this will be this gentleman lifting this pole here, which is weighted up and down in time with a metronome, so we make it nice and standardised. This is an arm ergometer. A lot of programs like these. Patients like them. they can get on and actually get a bit of a workout they feel. But in my mind, I've never ever had a patient come to me, ever, in clinical practice and say, the thing that bothers me is I just can't use my arm cycloergometer at home. They're of no functional use. So I wouldn't waste my time here. I would focus on this. And if they've got an extra 5 minutes, they'd be doing some more walking or cycling in my program. With regards to going through the literature for pulmonary rehabilitation, it can be pretty overwhelming. There is tons of literature. So I've just put these resources up here because I think they're probably the ones that are most useful and most practical. These are two of the position statements written by international premier societies. This is a paper here that we wrote, so myself and my colleagues, and it's a very practical how-to guide from clinicians about how to set up a pulmonary rehab program, how to prescribe exercise training, how to evaluate the rehab program and how to progress patients within that rehab program, and how to deal with non-attendance and how to deal with anxiety and depression, written by clinicians who have more than 20 years experience. So I think this is a useful resource. This is also a paper written by clinicians, which is very useful. But over and above all of these, I would very much encourage you to look at this website. This is a website that was put together by a group of physiotherapists and respiratory physicians in Australia. It's a practical step-by-step website. It's free, you can go on and have a look, and it literally goes through each individual component of pulmonary rehabilitation. It's peer-reviewed and it's updated regularly with all the latest evidence. So I would very much encourage you to have a look at this. So just to summarise briefly, COPD, it's strong evidence now that it's a systemic disease. The quadriceps dysfunction is characterised by a reduction in muscle mass, a reduction in muscle strength, and changes within the muscle that shifted away from oxidative capacity and towards anaerobic metabolism. There are multiple contributing factors, but the most important of which is arguably inactivity, and that's good news because we can reverse that. Pulmonary rehabilitation works by conditioning the peripheral muscles and increasing their oxidative capacity such that they produce lactic acid later in exercise and they perceive less dyspnea. Aerobic exercise training, as Darcy's already said, is the single most effective component that we can offer our patients with pulmonary disease, and in my mind it should be a standard of care. Thank you.